This webinar is brought to you by the Michigan Collaborative Care Implementation Support Team. My name is Sara Marasco, and I'm a training and implementation specialist with this team and a clinical social worker by training. Today, I will be telling you about the panel review process, which is that scheduled meeting time between the psychiatric consultant and the behavioral health care manager, in which they take time to review the collaborative care caseload. So you may remember these 5 core components of the collaborative care model, which we reviewed in our collaborative care overview webinar. There are a couple that are particularly pertinent to the panel review process, and I wanted to take a moment to touch on those. So population-based care, as you'll remember, means defining a patient population that is tracked in a registry. This is a specific group of patients that makes up the care manager's caseload, and with the registry, that ensures that no one falls through the cracks. We also have measurement-based treatment to target, which essentially means that we have treatment goals for each patient, and we are measuring and defining outcomes for each patient as well. These are reviewed regularly in the registry with the psychiatric consultant during panel review time, and if patients aren't getting better, we're proactively changing and adjusting treatments until clinical goals are achieved. So we've heard this term patient registry quite a bit now. What does a patient registry really look like? Well, it will depend on your organization and the resources that you have available in terms of what direction you go with a patient registry. A registry could be embedded directly into your electronic health record. It could also be a separate clinical system that either operates independently of your EHR or talks back and forth with your EHR, pulling information into the registry. It could also be a secure Microsoft Excel spreadsheet, which can work just fine. Again, it all depends on the resources your organization has available as to which direction you'll go with your patient registry. And that could change over time. For example, some clinics decide to start with an Excel spreadsheet as they work to build a registry within their EHR. It can take some time, so they might need this bridging option, so they'll use the Excel spreadsheet. We can work with your team to help you select the best way to go with your registry. And our website actually has a document available within the registry section that has some required and recommended and optional things that we list out that might be included in your patient registry and can really facilitate good patient outcomes within the collaborative care program and to help the panel review process go well. So this is just one example of a patient registry, and this is actually a screen grab from a registry that was a separate clinical system built within the Michigan Medicine Organization several years ago. But what I really want to point out here is some of the columns that are included in this registry. So you can see things like enroll date, so how long the patient was enrolled in the program. You can see the last PHQ-9 date, the last PHQ-9 score, whether these scores are going up and down. If your eye travels a little more to the right, you can see the last GAD date, as well as the last GAD score, and whether those scores are going up and down. That's referring to the GAD-7 for anxiety, just to clarify. And you can also see on here whether patients are flagging on the PHQ number 9 question, which indicates suicidal ideation. So all really important clinical information, and some registries include a little bit less than this, some include a little bit more. Again, I would recommend you reference that registry document that I mentioned is available on our website. But a really important thing with registries is that you can sort the columns so that you can sort of play with your data and make sure that you're not missing anybody. So for example, as I'm sitting down in panel review with the psychiatrist, I might want to really focus on the patients that are showing the most depression symptoms and they're really not doing well. So I might bring my eye to that last PHQ score column. And you can see here that you can click high at the top of this column. And if I clicked that, it would actually sort my patients by those with the most severe depression scores. So we could really focus on them and make sure that we do have recent recommendations into the chart, that we're making active treatment changes, that we're not missing anybody or forgetting about anybody, and that we're doing the best care that we can for these folks. And so you could really play with the data in a lot of different ways and sort these patients and make sure that you are giving everybody the focus that they deserve. So that was the patient registry. Now, when we talk about the panel review process, how often does it take place? When and where do we meet? What did the logistics look like? So for a half-time behavioral health care manager, so a 0.5 FTE, you're typically meeting with your psychiatric consultant 1 hour per week. And that's scheduled time, and it can often work really well to have that time carved out on the care manager and the psychiatric consultant schedule. So for example, it might be every Thursday from 1 to 2. You'll also want additional time available for curbside consults and questions. So that can just mean ensuring that your psychiatric consultant can accommodate some extra time per week to answer questions and be available for those consultations. Now, those things might not happen every week. Some weeks you might have extra questions and some weeks you might not. Sometimes PCPs might have some extra questions, sometimes they might not. But it's good to have some extra time available just in case. It can be an important part of that relationship. And in terms of where you meet, that can take place in person, in the clinic or in somebody's office off-site, or the panel review process can also take place via a HIPAA-compliant video conference. And that video conference system can be defined by your clinic. And that's actually happening more and more, especially as we know that psychiatrists are few and far between these days. So telemedicine is becoming more important than ever. So for example, we might have a psychiatrist, sitting 3 hours away from the care manager, but they're able to hold that live panel review session and talk in real time via video conference. So that can be pretty convenient. So we know when and where we're meeting for panel review, but how do I, as the care manager, prepare for a panel review session? Well, we want to really dedicate some time to planning ahead for it. New care managers typically need more preparation time than seasoned care managers. They're getting used to gathering what information they need and knowing what it is their psychiatric consultant will be asking about as they give their case presentations. New care managers might want to dedicate about an hour per week planning ahead for their panel review sessions, and typically that prep time will decrease as they get more used to the process. We'll go through what types of patients and what the format will be for going through a panel review session, but the care manager will want to keep in mind that they'll be talking about new patients that they've enrolled in the model as well as specific case questions. We do have a case presentation template available on our website that can aid the care manager in gathering the pertinent information and organizing their case presentations if that's helpful to you. But they'll want to be thinking about everything from labs to medication history to allergies to any medical conditions, as well as a variety of other things outlined on this template so they can be ready to talk about it in an efficient manner with their psychiatric consultant. So we talked about efficiency, and the reason being that we know our psychiatrists don't have a lot of time available. There aren't a lot of psychiatrists available. So we really want to leverage that time. That's a key piece of the collaborative care model. So the goal within a panel review session is to review about 6 to 8 patients per hour. So you probably don't want to be spending more than 3 to 5 minutes per case presentation because we want to allow for questions and documentation. So as the care manager, we need to be succinct, yet we need to be thorough. Our psychiatric consultant is basing their expert recommendations based on the information that we are providing. So we want to make sure that we have all of the information that is necessary to do so. Every panel review looks a little bit different. You might have more complicated patients one week, you might have less complicated the next week. So these numbers could vary a little bit, but we want to shoot for that average of about 6 to 8 patients reviewed per hour. So, you are a half-time care manager and you're sitting down in that hour per week that you have scheduled with the psychiatric consultant. Now what? Well, our team has a recommended format for moving through an hour of panel review, knowing that this hour can go very quickly and that we want to be efficient and cover all of our bases. We recommend starting with a brief check-in, covering any scheduling issues between the two of you, any workflow questions, or any updates about the clinic. We'd recommend not spending more than a couple of minutes on this item. Urgent patients. You may or may not have urgent questions that week that have come directly from the patients or are filtered through you from the PCP. We want to make sure to get to those, so try addressing those up front rather than waiting until the end of the panel review session. We don't want to risk running out of time. Specific case questions. So you might have specific things you hope to cover during this hour, including questions from patients about things like side effects on their medication or feeling like they're not getting better despite having been on their medication for a while. Or maybe a primary care physician is trying to make a choice between two medications and would like the psychiatrist's feedback. Now is the time for you to ask those specific case questions and go through these patients together. The psychiatrist may or may not put in treatment recommendations into the chart in response to these questions. New patients. Within collaborative care, we want to address and review new patients within 2 weeks of their enrollment with the psychiatric consultant. So we want to make sure to dedicate time for these folks and have the care manager go through their full case presentation so that the psychiatrist can put in any treatment recommendations if appropriate. And then after we've made our way through these first 4 items, we'll want to review the patient panel as a whole. We might want to focus on patients that are worsening or just not getting better, patients with PHQ-9 or GAD-7 scores in the severe range. Maybe we'll focus on those who haven't been discussed recently in panel review. We want to discuss each collaborative care patient at least once a month with the psychiatric consultant, so this can be an important item. We may also want to discuss patients who don't seem to be engaging in care. So maybe those are the patients that haven't had a PHQ-9 or a GAD-7 score entered into the registry for a while. And we might want to talk about why that's happening and whether we're doing everything we can and where we should go from here. And lastly, we might want to discuss patients that appear to be in remission or are ready for relapse prevention planning. So those might be the patients with PHQ-9 or GAD-7 scores that are very low and could either be discharged or moved on to a stable monitoring level of care, all depending on your organization and how you are approaching those levels of care. So when we think about reviewing a case, we have talked about that case presentation format. And I mentioned that we do have that form available on our website that you are free to use. But there are some ways that we recommend going about the reviewing of a case. So we like to say that the care manager should maybe present the case uninterrupted by the psychiatric consultant. And that might take 3 to 5 minutes or so, where they're really talking it through and giving all of the information that they've gathered in a systematic manner. And after that point, we'll give the psychiatric consultant some time to ask some clarifying questions. For example, maybe there are some pieces of information that the care manager hasn't yet gathered, such as the patient's substance use treatment history. The psychiatric consultant will ask about that and see if the care manager happens to know that information. If not, that's an opportunity for the care manager to make a note and know that they can go back and continue to assess the patient and gather more information over time. This will also include questions and discussion about brief interventions that the care manager has already worked on with the patient or maybe plans to conduct in the future. So then the psychiatric consultant will discuss their treatment recommendations, explaining the rationale for why they're recommending what they are, as well as what the care manager's role in implementation might be. So that might include calling the patient and checking in with them on a scheduled basis, recommending they come in for certain labs, or knowing what the titration schedule is going to be for a medication so that they know how often they'll be calling the patient. After this, the care manager, of course, has time to ask clarifying questions, including why a recommendation was made and how they might go about talking to the patient about a recommendation, what key side effects they might want to be aware of, things like that. And then the psychiatric consultant is going to document their treatment recommendations into the EHR. Ideally, we're assuming that the psychiatric consultant has access to the EHR. That is often the case, not always. They might also be writing up their note and either sending it to be scanned into the EHR or for the care manager to paste in the EHR on their behalf. Again, that all depends on your organization and what your registry looks like, and we can work with you individually to think about number 5 and how that might look for you in terms of workflow. But that documentation, in whatever way you do it, is very key, and that is going to be sent over to the PCP so that they can read over the recommendation and then decide if they're comfortable moving in that direction. And if not, that's one thing that happens, and that's okay because the PCP does remain the treatment lead in this model. So if the PCP is not comfortable with that recommendation, they can use the care manager to go back and ask additional clarifying questions, or maybe even ask for a new recommendation, and that's okay. We can go through this whole process again per patient just to ensure that everybody's comfortable. So I've mentioned that case presentation template a couple of times. This is a screen grab of the one from our website, and it covers a lot of the pertinent things that you will want to be discussing in panel review with your psychiatric consultant. So you can see the titles on here, but it includes things such as the patient's chief complaint, their outcome measure scores, their current and past psychotropic medications, any substance use history, as well as your initial treatment plan, among other things. So this can be a great guide for tailoring your case presentation within panel review, and using this guide can help you to move through it pretty efficiently within about a 3 to 5 minute case presentation. This is also a documentation example of what the psychiatric consultant might send to the primary care provider. So typically this will be entered into the EHR if the psychiatric consultant has access. This could also be scanned in or pasted in by the care manager. But it includes things such as recommendations, usually near the top of the note, so it's easily accessible by the PCP, as well as a brief summary of the patient, what the recommendations are, and we often see our psychiatric consultants putting in their rationale for the recommendation. It's an opportunity to teach the primary care provider why they might be choosing one thing over another. They can also include more than one recommendation, so maybe they're including a plan B if the patient or the PCP isn't comfortable with plan A, or if plan A ends up not being as helpful. They're also including the scores, as well as background and decision making, previous medication trials. You can see all of the headings here. There's also this standard verbiage that we recommend putting into the note that's sent over to the primary care provider. And you can see that on the right-hand side here. And it basically discusses that the psychiatric consultant is basing these treatment recommendations on their consultation with the care manager. And they haven't seen the patient in person. They haven't done that face-to-face assessment. And that the PCP should consider the patient's prior history, their current clinical status before implementing any of these recommendations. And again, they keep that line open where the PCP can contact the psychiatric consultant with any questions or concerns or clarifications after reading this note. That line is open, or they can use the care manager as a liaison to ask those questions or communicate any concerns. So what's next after you've gone through this systematic panel review process? You've covered your urgent patients, you've talked about new patients, you have talked about specific case questions, you've reviewed the entire patient panel sorting by different categories to make sure you're not missing anything. And hopefully you've been able to, in this hour of time together, review about 6 to 8 patients, which has required you to be pretty efficient, right? About 3 to 5 minutes per case presentation, sometimes less, and really being quick with that documentation, sometimes documenting while you're talking to one another, and sometimes having to wait until after to pop in any extra documentation. So after you've done that, you want to make sure that you have your next panel review time confirmed. Hopefully you have a designated weekly spot where you are meeting regularly, again, like that Thursday 1 o'clock time that I mentioned. But of course, vacation comes up and sometimes things need to be rescheduled, so always check in on this to make sure that you have that time set aside. You'll also want to confirm follow-up steps. So does the psychiatric consultant need to still get their documentation in and send that over to the PCP after you conclude your time together? Who do you need to call as the care manager? What PCPs do you need to contact? How are you going to reach out to them? You might discuss this briefly with the psychiatric consultant at the end of your panel review hour and just confirm what it is you all are going to do next. Your next steps as the care manager might also include liaising with PCPs of the patients that have had recommendations entered today. And I will go to the next slide, which talks about one way in which you could communicate with the PCP through the chart. So I'll revisit this topic. And then patient contact may also be next. So if you have had treatment recommendations put in by the psychiatric consultant, you might need to be calling your patients and discussing these and giving good communication and education about the recommendations and seeing how they feel about it. And again, I'll talk about that next too. So I mentioned liaising with the PCP, and this is just one communication example from the care manager to the PCP. It's going to depend on your clinic how you follow up with the PCP, but that might include sending a note through the EHR, sending an inbox message, flagging them in some way, or even just grabbing them in the hall, depending on what works for you. Every site is different and every PCP is different in terms of what's going to work best. But in this note, this is one way that the care manager might chat with the PCP after the treatment recommendation has been put into the chart from the psychiatric consultant. It includes information about what the recommendation was, just to jog their memory. They have a lot of patients. When the recommendation was put in by the psychiatric consultant, and just checking in with the PCP to see how they feel about it and whether they would like to move forward with it. If they are willing, you can even let them know that you'd be happy to call the patient to talk further about the recommendation, let them know that their PCP agrees, and to talk about psychoeducation and titration schedules and whether that's been sent into the pharmacy by their PCP or their nurse. If it's applicable and this is a medication recommendation we're talking about, you can also let the PCP know ahead of time that you'll be planning to follow up with the patient within 1 to 2 weeks or whatever the appropriate time frame for monitoring. Many PCPs have reported that they appreciate this. So it's really up to you and your clinic and your PCPs in terms of what's going to work best for acting as that liaison between the psychiatric consultant and the PCP. But again, this is one example that could work for you. So when you're following up with that patient, there are a few things that are pretty standard to cover here. You might start with reminding the patient of the psychiatric consultant's role. They may or may not be new to the collaborative care program, and this is often very different than what they might be used to or what they've heard of in terms of traditional mental health care. So you can remind them that you use the information that the patient provided with you during your last contact and discuss them in your weekly clinical meeting with the psychiatric consultant. You can also remind them that their PCP will be the one to prescribe the medications if that's relevant to this recommendation, and that the psychiatric consultant is more of a remote consultative role. Then you'll probably want to review your recommendations. So you're welcome to have that psychiatric consultant's note right up in front of you if that's helpful. And you can read through those, including any behavioral interventions, medication recommendations, psychoeducation that might be in there. If there is, for example, a medication recommendation, it can be really important to give good education about that. So that could include key side effects, what to expect, maybe how long it takes for the medication to start working, such as with SSRIs, where it can take a little bit longer. And then you might want to provide education about titration schedules, or if this doesn't work, then what you might try next. It could go a lot of different directions, but we want the patient to feel really informed, and that's a big part of the care manager's role. After you've given the recommendations and any psychoeducation, if you haven't done so already, make sure to elicit thoughts and questions from the patient. See how they're feeling. You've given a lot of information, so given all of that, what are you thinking right now? Where would you like to go next? And depending on what they say, go ahead and provide any clarification, any further information. And if they do ask a question that you're not sure of, that's totally okay. You can bring that back to the primary care provider or the psychiatric consultant, depending on the question. Next, remind the patient that their treatment choices are completely up to them. From a motivational interviewing and a patient-centered standpoint, we wholeheartedly believe this. So these are treatment recommendations. They are a menu of options that the patient can choose from and decide where they want to go next. Our role is just to make sure that they have all of the proper information and that they've heard our recommendations as a care team, and then they can decide. It's important to make the patients feel empowered, and often that leads to better outcomes when the patients feel that they are the experts in their own care. And then if the patient elects to begin a medication trial, or I should also say a behavioral intervention, discuss your follow-up plans. So depending on what it is, it might make sense to follow up within a week or two. Ask the patient if that would be okay. Could I call you in a week to see how you're doing? Could I call you in 2 weeks to see if you've been able to work on this goal? And also let the patient know that while you will be proactively reaching out, that they can call with any questions or concerns. Sometimes it can help to describe yourself as sort of their mental health point person, because it can often be easier to reach you as the care manager than the PCP, since our PCPs are so busy and might not have a direct phone number like you as the care manager might. So you can open up that avenue of communication to your patient as well, given that they might be making a treatment change. That can often provide a lot of comfort. And lastly, close the loop. So after you have that conversation with the patient, depending on what they decide, maybe send a quick note or pop by and let the PCP know what the patient decided to do. Let them know what your next steps are. And also during your next panel review, you can give an update to the psychiatric consultant or sooner as needed. So you've heard a lot about the panel review process today, and some key things to remember are just that this is a collaborative process and you're going to learn a lot as you move through the panel review process. You'll learn a lot about case presentation and medications and key side effects and different interventions that you can try with our patients. And you'll also learn how to make a panel review session increasingly efficient as you work through this process with your psychiatric consultant. It can be tough to get through 6 to 8 patients in an hour, and some weeks might feel very packed with patients and some weeks might feel a little bit lighter. So no panel review will look the same from week to week, but we want to try to follow this general structure to make sure that we are being really efficient and leveraging that psychiatric time, and really overall just making sure that patients aren't falling through the cracks and that we're getting everybody up to date needed treatment recommendations. So next steps in terms of training as part of the Michigan Collaborative Care Implementation Support Team, we would recommend working with your training specialists to practice those case presentations. So you might use that template that I mentioned before, and doing role plays can actually be really helpful. So a member of our team, including myself, could be available to work with you through those role plays. Or you could even work with another clinician that is in your area or a clinical supervisor to do so. We also recommend, if you have the opportunity, to shadow a live panel review session. And that's something that if you're working with our team, we can work to get that set up with you. It can really be helpful to see one in action and Oftentimes we hear feedback from clinicians that they really start to get collaborative care when they've been able to sit in on or remotely view a panel review. And then lastly, panel review coaching can be helpful too. This is often a very new process for people when they start to do these panel review meetings. It can be new for the care manager and for the psychiatric consultant. So it can be helpful for a clinical supervisor or a training and implementation specialist to sit in on these panel review sessions and maybe provide some feedback about efficiency and moving through cases at a good pace, and maybe asking any pertinent questions about follow-up with patients and helping you to sort through the registry in ways that you're not missing anybody, for example. So coaching for, about 4 panel review sessions, more or less, just depending on your psychiatrist and how you're feeling about the panel review sessions, can be really helpful. So do let us know if that's something that you would like to pursue, and that's something that we'll offer as part of our services as well. And as always, we have our website available to you, mccist.org. It has lots of resources available, including some about the panel review process. There is a panel review guidelines document that goes through much of what I shared here in the webinar today. So if you'd like to print that out and have a written format available to you as you work through panel review and get your feet wet with this collaborative care model, that could be very helpful. And again, we do have that case presentation template available as well, one that you can either print out, or it's also available in a fillable PDF format, so you can type in your information, which might be more efficient, and then bring that with you to panel review. Thank you all for listening today, and on the website we do have our contact information, so don't hesitate to reach out if you have any questions. I look forward to working with you again soon.